Hello, everyone. We're going to talk a little about intubation. Now, I have I've outsourced some videos for you to watch on how to actually perform the procedure, but I wanted to provide a little bit of a background on how we're going to be doing it, how we should currently be doing it. And it's just a little preamble to the videos that will teach you to how to actually do it. And I believe that when it comes to intubation, anyone can do it or not. No, anyone can intubate. But it's a matter if you can perform the procedure when it's actually indicated and without hurting the patient. As you know, we've worked a lot on intubation lately. We've had competencies on intubation. We've had cadaver labs where we have worked on intubation. And our success rates are not horrible. They've gone up. But I think there's a little bit more to it, and we'll talk about that. So anyone can intubate. They can intubate with proper preparation, with the right knowledge, with knowing your landmarks, with having the right technique, with choosing the right tools. And you can do it safely without hurting the patient, with having a backup plan. Sometimes I think we have too many tools in our toolbox. It's hard to maintain proficiency with VL, with DL, with a bougie, with a rigid stylet, with a regular stylet, with all of the tools that we have. So I think we need to focus on one. And one example, or a few examples of that are our rigid stylet, the one that is shaped to be used with our video laryngoscope. Now, a lot of people like the bougie. The bougie is in vogue, but unfortunately, the bougie is not meant to be used with a hyperangulated video laryngoscope, which ours technically is, because the angle is too acute. We're looking around a steep curve with our video laryngoscope. And unfortunately, even if you make that bougie in that curve, then when you insert it and you actually have to straighten it out, if you're actually using a good bougie technique, then it's going to, when you hit the teeth, it's going to straighten that out and it's going to deflect it posteriorly. So that is the issue with the bougie, and that's why I recommend VL on your first attempt, because we train with VL mostly, and most of you do VL. There are some services that have gotten rid of DL completely because they realize it's hard to be competent with VL and with DL. But also, it's also true that once you are an expert in one, it translates better to the other. But the service I know of that got rid of DL completely in Texas, this was Wilco, they did it just because they got VL, and their medical director said, I want you to use VL. I want you to use VL on the first attempt every time. And they had paramedics that just refused to do that. Now, we don't have that issue, fortunately. But because their paramedics said, well, I'm good with DL, I'm not going to use VL, they ended up having to get rid of DL completely. I think they just keep one straight blade for pediatric or just for foreign body airway obstruction to use the McGill's, but otherwise they don't even intubate pediatrics because they have such few cases that they can't maintain proficiency with that. When you're going through this training, I want you to visualize each step of the process in your mind. You can even move your hands, but I do want you to interact with the training and think about it. Visualization is powerful. It's been proven that you can get better at a skill without actually even physically performing that skill if you just perform your own mental simulation. Now, our goal is not to just intubate. That would be a pretty easy goal if all we cared about was improving our intubation success rates, because then we could keep going and keep going and keep trying, and eventually someone can get the tube. What we care about is the -1A metrics, which is obtaining a definitive airway without hypoxia or hypotension on the first attempt. So yeah, when we actually implement delayed sequence intubation, we'll have to track these metrics. Did we get the airway on the first attempt without hypoxia or hypotension before or after the intubation? Now, I like rules. I like things that are easy to understand. And I'm sure everyone is familiar with the rule of 15s. Well, this is the rule of 90s. We want our success rates to be 90% at least on the first attempt. We want the SpO2 to always be greater than 90, and we want the systolic blood pressure to be greater than 90 within 90 seconds, and that's played in to monitoring end-tidal CO2. But how do we do that? Like, how do we actually become that good? Well, first, I think the key is to knowing your landmarks. And the video that you're going to see after this perfectly describes how to identify your landmarks. It is a progressive approach. Dab, dab down the tongue, find the epiglottis. Don't overshoot your target. Go incrementally until you find that epiglottis. Go in midline. Once you see it, seat the tip of the blade in the vallecula, because the epiglottis is what you're looking for. If you are anxious and aggressive and you just insert it, then usually you're going to go too deep, bypass your target, get lost in a sea of mush, and never be able to find what you're looking for. Because that epiglottis is key. You know that if you go under and north, right? If you go north, let's say you're going north to Lexington, then that is your destination. That's where you want to go. But if you go south to Danville, that's where you never, ever want to be. All right, so you made a wrong turn. So north is Lexington, south is Danville, where you don't want to go. It also helps knowing how the epiglottis is situated in the mouth, right? And it's also worth knowing that even if you have this view on the left of your screen where you don't actually see the chords, but you see that those notches, if you go north of those notches, then you're in the trachea. If you go south, then you're in the epiglottis. So you don't have to have a perfect view to intubate. And in fact, the view on the left is best because you are higher in the airway. If you go too deep and have a perfect view, then it's going to be hard for you when you try to pass that tube because you're looking up at your landmarks instead of looking down. And the proprioception of where you are in the mouth makes that difficult, knowing exactly where that is. And when you go to pass the tube, each time you're going to go posteriorly instead of up where you want to be. So it's always best to stay high and dry in the mouth. When we intubate, we want to be like a gazelle. There should be no rush whatsoever. Time is on your side when you're trying to intubate. If a patient is in cardiac arrest and we don't have a good marker for knowing how long we have attempted that intubation, but nevertheless, our goal is still to be slow and smooth because if you rush it, you're more likely to not be successful on the first attempt, which could possibly result in interruptions in CPR, or it could result in further attempts with the patient being void of oxygenation and ventilation even longer than if you just took your time and focused on getting it the first attempt. So we don't want to be all over the place in the mouth. We want to have a steady trajectory down the tongue to the epiglottis. So be like the gazelle. Time is on your side. And a lot of people think, I only have 20 seconds. I only have 10 seconds. If I hold my breath and when I have to take a breath, then the patient needs a breath. Well, that's a problem because, one, you shouldn't be holding your breath while you're attempting to intubate. That doesn't do anybody any good. Most people are like this cat, just all strung out, all anxious. Before you go in to perform this procedure, take a deep breath, remain calm, visualize what you're trying to achieve. Visualize the steps that are described in the training that will follow. Remember the 5 P's. Now, there are more P's if you are doing, if you're performing RSI or DSI. But right now, this is what I want you to focus on. Positioning, pre-oxygenation, preparation, then placement of the device, and post-intubation. Knowing when to pull the triggers is important as knowing when to keep it in the holster. Perfect example of this is our excited delirium patients. Just because we give ketamine and fully dissociate that patient and they are unconscious, that does not mean that they need to be intubated. Patients get ketamine all the time, and the majority of our patients, they get ketamine, they go to the ER monitors them, they wake up, and they're discharged from the ER the same day. Most of our patients that we administer ketamine to are not intubated, and they leave the hospital. So that doesn't mean that you need to intubate them. There may be other extenuating circumstances surrounding the case, and you may think that you need to intubate them then, and that's probably okay. But what I mean by keeping it in the holster right now is we know that the definition of an intubation attempt is when any device passes the teeth. So if it is your laryngoscope blade, once that passes the mouth, right? Once it enters the mouth, or passes the lips rather, that isn't an attempt. Even if you just barely insert it and then you pull back and say, no, the patient's clenched. We need to identify these patients that we cannot intubate, that are not a good candidate for intubation, before we even make that attempt. Now, a good rule of thumb, and my rule of thumb, is if I cannot insert a OPA, then I probably should not be intubating this patient. So now if we move forward and we get DSI, then it's a moot point because you'll be able to sedate and then paralyze the patient. But nevertheless, right now, choose your patients. Select your patients wisely. That doesn't mean that I don't want you to be intubating. We should still be intubating if we think that it's a good candidate. But at any point, even before our goal was to improve our intubation success rates and move forward with DSI, it still wasn't a good ideal to attempt intubation on a patient that had trismus or masseter tone, because your chances of being successful during that procedure are significantly lower than if they had full relaxation. So one of the other P's is positioning. If you want to maximize not only your success in intubation, but to prolong the period during apnea in which the patient's SpO2 will stay at above 90%, 94%, then you want to elevate the head. You want to put them in the ear to sternal notch position. That is, the ear hole is aligned with the neck hole. It's not like this. Okay, this is the bad sniffing position. This is the good. Head forward. This is sniffing the morning air position. This is the good position. If you really want to be good at intubation, then you will bring the ear forward in line with the sternal notch on a horizontal plane, and you will also raise the head of the bed about 30 degrees because that gives the patient a higher lung capacity as well. So positioning is key. Even in cardiac arrest, put something under the head. We want to pre-oxygenate our patients. We pre-oxygenate because, so if the patient has a pulse, we pre-oxygenate because if the SpO2 is anywhere between 94 and 100%, the rate at which the SpO decreases once you remove your oxygen delivery device is gradual. Below about 94%, it drops off dramatically without warning You no longer get this gradual decrease in SpO2. So if a patient has a pulse, our goal is to get that patient up above 94% before we attempt placing an airway device. So how do we do that? Well, we resuscitate before we intubate. O2 via nasal cannula, generally around 15 liters. BVM, generally around 15 liters, although you can go up to 25, 50 if that's possible. And PEEP. Now, let me clarify something real quick. We do not use this process on patients that are in cardiac arrest. We do not want to increase PEEP. In cardiac arrest, we want PEEP around 5. If they're not in cardiac arrest and they're hypotensive, then you have to use good clinical judgment, because we know that high PEEPs can decrease preload. So that will be at the discretion of the lead medic. But the general rule is 15, 15, 15. Now, why do we run a nasal cannula under the BVM? There's 2 reasons. The BVM has a valve in it. If the patient is not actively breathing and you're not squeezing the BVM, air does not get to the patient. So if the patient's apneic and you just hold that BVM over the face, air's not getting in. If you have a nasal cannula on underneath the BVM at around 15 liters per minute, then that is going to keep that valve open. And you're essentially creating CPAP because you have a PEEP valve on. So you can with a nasal cannula underneath the BVM and a PEEP valve, just hold that on the face and have apneic CPAP. It is debatable on if the patient is not breathing, should we squeeze the BVM? And generally RSI, the purpose of RSI was to paralyze the patient without having to provide any positive pressure ventilations, because so that you would not insufflate the stomach and increase the risk of vomiting and aspiration. But there have been multiple studies showing that it is actually safe to squeeze the BVM. Now, there might be times where you don't need to. If the patient has no underlying lung pathology, if their lungs are normal, then you should be able to get away with the nasal cannula of the BVM and the PEEP valve, even if they're apneic, although you have to appreciate that the CO2 is going to climb. Now, if this is a DKA patient that is severely acidotic and they're not breathing effectively, well, then you still have to ventilate them. You have to balance the risk of gastric insufflation and worsening metabolic acidosis. And again, all of this will have to be based on your fundamental knowledge and clinical gestalt during the call. So another reason that we put the nasal cannula on is no DSAT. Nasal oxygen delivery, nasal oxygenation during efforts at securing the tube. No DSAT. Now we know that, let's say we're ventilating the patient, we get the SpO2 up. This is in a patient that has a pulse. We get the SpO2 up. We remove the BVM. We're attempting to intubate. That oxygen from the nasal cannula continues to flow passively down into the lungs. And it does provide some oxygenation. And it prolongs that period of no oxygenation, of when we're not actually actively ventilating the patient. It prolongs the apnea period. This is why you don't have to rush, especially if you're intubating a patient with a pulse that is not apneic and is a good candidate for intubation, because you have the time. And we don't care so much if the CO2 rises a little bit in most patients. In most patients, it's not going to hurt. In some, it might, and you have to know who those patients are. But while you're intubating, just know that that oxygen from the nasal cannula is continuing to flow into the lungs. This is probably less effective in patients that have shunt physiology in the lungs. So if they have pneumonia, pulmonary edema, you know that in those patients, supplemental oxygen without PEEP or CPAP typically is not effective. It only marginally raises the SpO2, and you have to apply some sort of positive pressure to keep their SpO2 up. But nevertheless, we still keep the nasal cannula on because a little bit is probably better than nothing, and it's not going to hurt the patient. But you should know that if your patient required high PEEP and a high percentage of oxygen to get the SpO2 up, then their O2 saturation is going to decrease much more quickly without that. So time is on your side. In the new protocol that we've submitted, and here is just a preview, a premiere of what that will look like. It is not approved, and it is subject to change, but this is the general sequence. All right, first you apply your monitoring equipment, you prepare everything, and then you resuscitate before you intubate, right? You have to have continuous SpO2, continuous end-tidal CO2 throughout the call. Even in order to proceed with this procedure, you have to be able to monitor SpO2 and end-tidal CO2. A lack of either of those two require you to abort the procedure. And of course, we're going to address any hypotension with push-dose epi with a goal of systolic greater than 100. And that's when we provide our induction medication, which would be ketamine. Now, when it comes to providing oxygenation, we provide the most aggressive form in the beginning during this preparation step. Up here, during this preparation step, we provide the most aggressive oxygenation that the patient will tolerate. That would be the most aggressive would be the rule of 15s, the nasal cannula, the BVM, and the PEEP. If a patient does not tolerate that, then we apply nasal cannula with a non-rebreather at maximum flow. At which point we would provide our induction, which is ketamine. Then we would provide the BVM, two-handed, thumbs down, seal, and we would increase PEEP as needed. Once that SpO2 is above 94%, we allow 3 minutes for the nitrogen to be washed out, because your lungs are made up mostly of nitrogen, and we wash that out and we replace it with oxygen. And you have to have a continuous of a 94% of SpO2 for the entire duration. If not, you have to repeat the countdown. Then you paralyze the patient, you perform intubation, and of course, you'll see in this procedure that there is no minimum time required of how long it should take you, or no maximum of how long it should take you to perform the procedure, because our metric is the SpO2. Once that drops below 94%, we stop the procedure, we abort, and someone else's eyes will be on that monitor. And we can do that even right now. If the patient has a pulse and you're attempting intubation, have someone watching that monitor and marking the SpO2, and we can empower everyone in our department to know when it's time to abort. And now I want you to go forward, watch this training with great interest, pay attention, learn it, and visualize it. If you're a paramedic and you want to be able to be credentialed as a DSI provider, you're going to have to take a comprehensive exam. There's a lot of self-studying you will have to do, and a lot of the stuff you will need to know is included in this lecture and the following ones, so it is imperative that you pay attention. I do want to go back briefly and talk about one thing that I didn't fully cover, and that is monitoring end-tidal CO2. Anytime we are ventilating a patient with a BVM, we must monitor end-tidal CO2. The AHA just came out with their 2020 guidelines, and they now recommend that. That means if you are ventilating a patient with end-tidal CO2 monitoring on and connected, and you're not getting an end-tidal CO2 reading, something is wrong. Something is wrong. Do not assume that you're just not getting a reading or that there's something wrong with the device or the monitor. That can happen, but the most likely explanation is that the airway is not patent. BVM ventilations are not automatic. You don't just throw it on the patient and automatically have a patent airway where you can just squeeze the bag and empirically and immediately ventilate that patient. That's not how it works, especially in adults. You have to use perfect technique. If you aren't getting end-tidal CO2, troubleshoot. Find out why. If that airway is not patent, what else matters? If the patient does not have a patent airway, unless they are exsanguinating from an extremity, nothing else matters. You have to ensure airway patency. And the only objective way, the only defensible way is with end-tidal CO2. And it is imperative for you and your patient that you ensure continuous waveform capnography is being displayed. All right. Now, I hope you enjoyed that, and I hope you enjoyed the following videos. And I do want to reiterate that this protocol is not. This is just draft. It may look like this when it comes out. It may not. But we will have another training specifically on it. And let me know if you all have any questions. Thanks.